Hi, and welcome to our first practice exam. So I'm going to explain a little bit of how this works, but the idea is to be able to give you a chance to assess where you are with the content prior to taking the exam. So some of these questions are going to be similar to exam questions, or they will definitely be on the same kind of content, and they may just be asking a similar question in a different way. So as you go through these slides, I will be explaining the content in a very brief way. So when a new slide comes up, you are recommended to click on the blue dots immediately. It will automatically stop the video and it will allow you to test your knowledge and take these practice questions. Please know that this is completely anonymous. I can't see if you even access this or not. I can see how many people access it, but not who, and I won't be able to see if you got it right or wrong or anything like that. This is completely for your benefit. And then once you're done with those questions, the feedback, if you get it wrong, will tell you where to find it in the modules, or how to figure out the question better. And then you can move on to the next one. And then if you once you're done with the questions, click out of them and the video will continue and I will do a brief description and explain that content. So you can learn some of it there, but please know that the more in-depth explanations are going to be in those initial videos I made within the specific modules. So as we start getting more joint specific, I will not have the really good models that I had in those initial videos that I had borrowed. So please always go back to that area if something is really confusing to you and watch that specific video. If you have any questions about this, please reach out. So we're going to start with hips and hops, and this is a way that we assess injuries. So hips stands for, so the H in hip stands for history. So you're asking them questions. The I and the O stand for inspection and or observation. So it's what do you see? What are you seeing there? So this is like swelling, bruise, an obvious laceration, a contact point, or swelling. And then the P is palpation. So what are you feeling when you touch it? Are you feeling swelling? Are you feeling warmth? And then the S is special test, which is something we won't do at this level, but something you would do in a professional program when you're learning how to do specific testing, to be able to see what that means. When we talk about different range of motions, you see a PROM, AROM, and an AAROM. It stands for passive range of motion, active range of motion, and active assistive range of motion. So passive is just like passive. You're letting it happen to you. So the person is not moving their, let's say shoulder, they're not moving their shoulder, and a clinician is moving their arm for them, and there's no movement done by the person. Active range of motion is you're being active in that. So you're actively contracting your muscles to move with no other assistance from anyone else. And then active assistive is if I had something to push up. So you're actually being assisted with the motion. So I wasn't planning for this, but I have a hammer. So you're going to be like this, and you're actively trying to move your muscles while also being assisted with something else. So usually a pole or a crutch. Not usually a hammer, but that is there for you if you need it. And remember that ROM stands for range of motion. So how much motion do you have in a whole range? So can you go from 0 degrees to 180 degrees? What is that? So these are the different ways we assess, because we're looking at, is your joint motion good? Is it your muscles that aren't working? And do you just need assistance, and can you do that? When we talk about the 4 phases of therapeutic exercise, so we introduced this and said it goes along with the healing phases. So when you get into a profession, or if you get into a profession that does rehab with an injury, you need to know that there are 4 phases that we basically call them these phases because there are certain exercises that go in. So phase 1 lines up with phase 1 of the healing process, which is the inflammatory process. So the inflammatory phase. So everything is angry and swollen for about usually 48 to 72 hours. So what we do in that phase 1 is we control that inflammation with usually cryotherapy and modalities. And then phase 2 is going to be proliferation phase. So this is where you have those initial cellular phase where there's trying to lay down, trying to get all the good stuff in and the bad stuff out. And it's starting to calm down. You don't have as much inflammation, and it's starting to really start that kind of healing phase of laying granular tissue down. And then and so in that phase, we're just going to assist with motion, but we don't want a lot of strain on those fibers. So we're not doing any strengthening yet. And then in phase 3, we have early remodel. And so late proliferation, early remodel. So this is where you're laying that granular tissue down. We're starting to get that really like flimsy type 3 collagen down that isn't super strong. But you think of like a scab being laid down right before the skin lays down. So the scab is on there. And so you can start developing strength, but you can't really bring those you can't put a lot of tensile force on those structures because they're not super strong yet. And then in the last phase, we have late remodel maturation phase. And this is where we're really pushing like heavy strength, but return activity. So this is in phase 4, return activity. We're doing functional exercise. So we're mimicking the same exercise you would do in a sport. Part of this, with the phases, when we're doing any kind of intervention, we use therapeutic exercise and we also can use modalities. So cryotherapy, it will be important on the exam we're not going to get into a lot of modalities in this class. It's just to understand kind of why you would be using them, what the objective are, because I'm introducing them because they might come up a little bit when we talk about like treatments and things, and they might be doing ice or they might be doing ultrasound. I just want you to understand like what they're trying to do. So you just need to know what these are and what the objectives are. So for cryotherapy, we're trying to vasoconstrict, we're trying to get the inflammation down, we're trying to lower the body temperature. Superficial, very superficial. Thermotherapy is heat, and these are like heat packs and things like that. That is superficial heat. So we're raising superficial body temp and we're trying to like, maybe increase the cellular process a little bit, but mainly it's just like superficial heat. Ultrasound is used in 2 ways. There's continuous ultrasound and pulse ultrasound. So ultrasound warms up, heats up the tissue at a deeper level than thermotherapy, like than heat packs do. But technically it's a type of thermotherapy. So continuous ultrasound. So when we say ultrasound, just know that it can heat at a deeper tissue than heat packs. And then it also optimizes healing process by speeding up that cellular process. And then e-stim, so electrostimulation, that is re-education of muscles and also pain control. So different variations and frequencies and how you set up that will do different things. And research goes back and forth on how effective those things are. But at the end of the day, that's why we do those modalities on injuries. So we're going to move to module 2 now. And so in module 2, we're starting to lay down those basic kind of biomechanic foundation here. And so we start talking about mechanisms of injury. So there's 4 main types. And on the exam, you will need to know, like looking at an injury, what kind of mechanism of injury was that or what it was. So compression is when you're being forced in. So I love this model of like thinking of the knee. So if it was pushed in the tibia into the femur and you would bruise the meniscus and bone bruise there, the bone, if it's a really big impact, that's compression. So when something is compressing into each other, going into each other. Tension is when it's widening. So when there's tension on a structure. So for this example, it's tension on the MCL, the ligament that's on the medial side of the knee. So it's just pulling. Muscle strains are also a very good example of tension because it's just pulling over time. And then eventually it gets to the point where it can't withstand the amount of pulling and tension, and it can tear. Shearing is when they're going in opposite directions. The forces are going in opposite directions. So this would be an ACL tear because the tibia is moving anteriorly, femur is posteriorly, and it tears the ACL. And then the last one is torsion. It's when both ends are being twisted and pulled away from each other. But it's the twist that is the distinctive factor in torsion. So this is like tibia fractures, spiral tibia fractures, when the foot is like fixed and the foot and the leg is like pulled this way and it's like twisting. Understanding like how and why injuries happen is a big part of this module. That's pathomechanics. And so a big part of understanding this is how stress is distributed. So looking at this, you should be able to look at this and tell me, is there more stress or is there less stress? So even though, so the area is larger, so you might, your brain might be tricking you immediately to think, oh, there's more stress because it's more area. But there's more area to distribute that stress. So if the force is exactly the same, which is what is in this picture, then that same force on a larger area is going to be less stress because it's distributed more. And then so the same force on a smaller area is going to have more of an impact because it's less area to be distributed. And so this has a big impact on whether an injury occurs, on how much area, but also the type of tissue it's on, and does that have the ability to kind of bend before it breaks. And this brings me to chronic versus acute and micro trauma and macro trauma because these also feed into this. So let's start with micro trauma and macro trauma because it's very similar and has a big impact on the part where we were talking about stress distribution. So when we look at micro trauma is when there's small, low load, high frequency. So with micro trauma, you have like these little forces in a small area, or a macro trauma. So micro trauma is usually with chronic, right? So it is low load, high frequency. And so a chronic injury is something that's taken a long time to develop because it's had a lot of frequency of impact, but really small. So this is common in a muscle strain. So you're running and your hamstring's really tight and it can't withstand the pull that it needs to. So over time, it slowly has that tension, slowly. So it's little frequencies over time, but it's not enough to really tear that hamstring in half yet. But if you just keep doing it over and over again, eventually it's going to start tearing. And then a macro trauma is usually with acute because this is a big load, high load, low frequency. So usually it's like one time. So this would be like I fell from a second story window and broke my arm into a million pieces because it was a high load that my bone could not withstand, but it only happened one time. Make sure that's clear. And if it isn't, please go back to that video and module 2. That will explain that a little bit better. Now we're going to talk about torque because torque has a big impact on joints. So it's always going to be at a joint where it can rotate, especially a hinge joint. So this is elbow and knee has a big part in this. So torque is rotational force. So it's the rotary effect by an external force. And so I have it on here, but I like to think of a door. And I think I explained this in my initial video. My kids love to go outside and push a door all by themselves, even the really heavy door at daycare. And I've explained to them that if you are close to the hinge where it opens, you can't generate torque. So the longer the lever arm, the more torque you can generate, the more force you can then overcome that hinge. And so if you're right by the hinge and you try to push, you have to push way harder than if you were all the way by where the door opens. You have a longer lever arm. Same thing applies to an injury. So I love this example. I have the colors on here. If you're near the elbow, you're not able to generate much torque on the forearm. And so if an injury happens right here, it's usually not going to dislocate the elbow. But if someone falls and lands at their hand, and they land like upside down, for example, like a gymnast or somebody lands upside down, a wrestler when they're thrown upside down and they land, that's a really common time for the elbow to dislocate because the force and the torque on that is going to be so much greater. Same thing with baseball. There's so much torque when you're throwing because the ball's on the end and you're having to torque this whole thing, the whole forearm back, and it puts a lot of torque on the elbow. So just understand the longer the lever arm increases the torque. Also understand that torque is rotational force. And then the last thing here is that we're going to talk about with the load deformation curve. I said in the initial video, this is really complicated if we really teach it. It's very complicated, but you will add this on if you go on into graduate programs. But what I want you to just understand, the basic here, is that every tensile, so every structure we have, right? And as we go on to modules 3, 4, and 5, you're going to learn the different strengths, the tensile forces, the compression forces that these bone versus ligament versus tendon versus muscle can withstand for injury. And so this is what this line that goes up in curves, right? So everything can take a certain load, and then there's a yield point. Where it curves is the yield point. You need to know that. So I took the arrow away, but you can go back to the module and see it. But it's right where it curves and that dotted line is going up, because this is where injury starts to happen. This is where the breakdown starts to occur. And you have to try to then intervene on that, decrease the load, do intervention with like exercise to make it stronger, modalities to help with that. You need to intervene before you get to ultimate failure point. And if you don't intervene, or the force is just so great in that one moment and the structure wasn't able to then bounce back, then it has the ultimate failure point. So yield point is where there start to be some kind of breakdown in the structure. So we go from the elastic being able to take on some, but then it goes back, but it's never quite fully back, but it can go back to being functional, versus like we start getting into that plastic region where it's not able to go back to where it originally was anymore. And there's actual breakdown happening. If you have any questions, please reach out, but please go back to those specific modules and make sure you are filling in bridging those gaps of knowledge. Take a note sheet, base it on this study guide, and then highlight all of these areas that I targeted today in the practice exam, because they will show up on the exam. And go back to those notes sheets and fill in the information that you need that will help you do well in this exam. And if you're still having questions and still can't answer your questions in the module, that's when you reach out. Good luck.